We're going to make a start and others can join us. Absolutely delighted that you've come to this session on reshaping urgent health and care in Coventry and setting up for an integrated future this morning. My name's Sarah Mitchell. I'm going to be chairing the session. I'm an advisor for Newton, but with a background in social care. And one of the most exciting things I think about this and what we're going to hear about is really good relationships between health and social care as part of this project, which I feel really pleased to be hearing about. So without any further ado, I'm going to hand over to Leslie and she's going to introduce the session.
Good afternoon. Before we get started, we're just going to introduce ourselves. So I'm Leslie Terry. I'm Head of Integration at University Hospitals Coventry and Warwickshire, and I'm the Programme Director for the Improving Lives Programme.
Delivery at University Hospitals Coventry and Warwickshire.
I'm Joe Greasley, Principal Consultant at Newton Europe.
Afternoon everyone, Matt Deacon-Smith, Director at Newton Europe.
Okay. Just a brief overview of today's session. We'll start with a presentation to give you the context and the background of the programme and set the scene for you. Then we're going to have a panel Q&A. Sarah's going to ask us some of the challenging questions that you'll all be wanting to ask us when you hear us finish speaking. And then there'll be an opportunity at the end for you to ask questions. We have an ask from you. There's a lot of knowledge and expertise in the room. I can see my Chief Exec and Koo are here, for example. Thank you. So we would like to get advice from you. As you know, what advice would you give to us trying to land this large-scale transformation? And also to put in the Menti what your questions are going to be. If you don't have time to scan it now, we'll put this up on the screen during the Q&A, so you don't need to worry about doing it right now, but keep that in your mind as you hear us talking. Okay, so before we get started, a bit of a context about Coventry. So, it's a city in the West Midlands, about 345,000 people. We have really diverse communities in Coventry and significant levels of deprivation across the city, and all the health inequalities that come with that, and that's quite important, and we'll come back to that later in the programme. In terms of our providers in Coventry, the population is served by University's Hospital Coventry and Warwickshire. It's a large acute teaching hospital, 1,100 beds. We are the local provider for Coventry and Rugby, but also a specialist and tertiary provider for the wider region. The Coventry City Council provides adult social care, and the Coventry and Warwickshire Partnership Trust are our community provider. They're also a mental health provider for the system. We are served by the West Midlands Ambulance Trust, and we have 8 primary care networks in our health and care system as well. I think the important thing to say about Coventry in the context of this programme is that when we started, we've got multiple providers in this space, but really limited integration between health providers and between health and social care. So that's the starting point for this. So why did we decide to do something about urgent and emergency care in Coventry? Well, as I'm sure many of you in the room are dealing with the pressures of urgent and emergency care on a daily basis, it's a priority for everybody across the NHS and adult social care. But particularly in Coventry, we are an outlier in terms of ED attendances, admissions, length of stay in the acute, and also the level of patients we are putting into bedded care or quite heavy care packages when they come out of hospital. So we knew that there was an urgency to do something to address that, not just because of the daily pressure we're facing in terms of ambulance handovers, ED pressures, adult social care capacity, but just that sense of acknowledging as a system that we weren't doing a good job and we needed to do better. And that's a really important theme throughout this programme, is that personal sense of responsibility in our leadership. So you'll see on screen we've got chief officers from the acute, from the Community Partnership Trust, Director of Adult Social Care, Pete Fahey, and Maddie is our CFO in the ICB. So we've got absolute senior leadership behind this programme, and that real personal commitment and that feeling of doing nothing on this isn't an option anymore. And as you can hear us talk through the level of change in this programme, you need a strong leadership team to make this stuff happen. So we decided we need to do something about it, and the first step that we took was a diagnostic. And I want to talk about this a little bit because in my experience in the NHS, we sort of understand that we have problems and we jump into solutions. But what we did in this programme was we spent a lot of time diagnosing what the issues were, and we brought Newton Europe in to help us with this part of the programme. And of course, we did a load of data analysis and we looked at the operational financial side of it. But the bit that really made the difference was the multidisciplinary, multi-agency case reviews. So we got our clinical and operational and adult social care teams around the table. We did an intense review. It was heavy lifting, this, but it was worth it, of about 150 patients. And the really important thing about this is if you listen to people talk about why they made decisions, you start to understand where the problems are. So, ED doctor talking about why they made the decision to admit that person. Community response team talking about why they made the decision to convey. And you start to get that real picture of what the problems are. And some of it was a bit surprising, actually, because, from the hospital perspective, we came into this with the problems are all out there. If they could just sort out social care in the community, it'd be fine. By the way, they think the same thing about us, They could just sort out what's going on in the hospital and use us better. But if you really, really listen to staff talking about that, you get to the crux of what's going on. And it isn't a capacity problem in Coventry. We'll talk more about that in a minute. So we understood what the problems were, and what did we find out? So you can see from this, if you look across that whole pathway, there's opportunities at every step here to make an improvement. There's a role for every organisation to play in this. It's not just a hospital problem. It's not just an adult social care problem. It's not just a community problem. Everybody's got a role to play, and it only works if you play together. And just a note on this, we started this programme looking at the older population, but we quickly realised we should apply this for all adults in Coventry. It makes sense, doesn't it? So the three key things that we learned that were driving this picture, and really we learned it from the case reviews, was the services are available, but people don't know about them. So if you're in the ED and you're trying to make a decision, and you don't know that there's an alternative out there in the community, you won't use it. Okay. It's all fragmented, so it's not easy to quickly put the right support in place to respond urgently. And you know what it's like when people are busy, they will take the path of least resistance. If you make it really difficult for people to make the right decision, they won't make the right decision. And that's kind of setting our staff up to fail. And what really, really drives a lot of the decision making, which is quite risk averse, is that people don't feel confident that there is another service there to use. So if you're trying to make a decision about your patient and you don't feel confident there's someone else there to take the baton from you, you're not going to use that service. So you're getting a picture here of, we have enough capacity in our system to do this, but the way that we've organised our services, the way that we've structured things, makes it difficult to use that capacity effectively. And that's a very different understanding to what we thought at the beginning of the diagnostic, which is we don't have enough capacity. And the good thing about that is, it's not a funding and investment problem. It's not, let's do a business case to invest in X. It's a structure problem. And that's our job to fix, and we can do that. So the diagnostic was really important, because now we know what the problems are that we need to fix. Okay. So our ambition, what are we going to do now? Our ambition is to deliver a health and care pathway that responds to patients' needs, is built around the patient, delivers improved outcomes and higher levels of independence for our people in Coventry. It improves the experience of staff so they can do the job that they want to do and not spend their time referring and on the phone. And we have to have a system which is operationally and financially sustainable, because there's no more money to do this, obviously, you all know that. And we believe that the way to deliver this is to have integration between health and social care and to build a system that's based on people working together. So now we're going to talk a bit about, well, what are the features of that model then, and how is it different to what we did before? So I'm going to hand over to Cara.
Okay, thanks, Leslie. Okay, so I'm going to start by talking us through what we've tried to do with our local integrated teams. So as Leslie's described previously, what we had was a number of different teams that worked in silos with referral forms between all of those different teams and services. And naturally that meant delay for our patients, backlogs between services. What we've tried to do here is pull together a group of individuals from all three of our partner organisations. So that's social workers, carers, occupational therapists, physios, nurses, and they are physically co-located in one place and they manage a caseload of patients that come through our health system in Coventry. So we're currently trialling a team that can manage and cater for a third of our population, and this has been over a series of the last few months in designing this model. So our individuals that sit as part of our local integrated team have a twice weekly MDT, and in that MDT, our patient caseload are reviewed. What's different here is that the way in which we describe and manage the care for our patients is around what those individuals actually need. So we don't have a prescriptive response. It's based on what is right for that individual. But most importantly, it's around what's the goal that that individual wants to achieve in partnership with their family, and for them as an individual, what's right and meaningful. So when we talk about goals, this isn't about something generic like achieving independence might have been something we'd have said previously. This is now very specific. What is it that they want to be able to deliver in their normal working life that they might have been able to do previously and now can't do? So is it being able to go to the shops every week or something along those lines? Very specific to that individual. And the MDT operates in a way that we are progressing towards realising that goal for the patient or the resident that we're supporting. So what we're trying to understand at the moment through our integrated teams is the number of individuals that we need it within that workforce model to deliver a service for a cohort of patients. That means that we retain that level of familiarity and oversight of those individuals, retain the level of oversight of their goals, and then scale up that model. And this has been really, really exciting to see this happen. Some of the benefits that I think we didn't anticipate are things like having individuals that are in a room together in an MDT. The next day someone will be taking out a piece of equipment and someone else will say, don't do that, I can take that because I'm already seeing the patient. And what that means is that the individual doesn't need to tell their story more than once, and I'm sure everybody's familiar with the frustration that can create. They tell their story once, and the team are familiar with that patient, their progress, their challenges, what their family dynamic is, and it's that level of familiarity that we're really aspiring for. So through this coordinated, integrated team, we have seen more than 200 patients through this pathway now, which we're really proud of. And what I'd really like to show you now is one of our patients, Zena, and her daughter, Christine. They're going to tell their story.
So Mum had a fall in her home and ended up in hospital for roughly 2 months. So she had some physio in the hospital and then needed further physio when she came home. Yeah, in the hospital they told us that we would have a service in the home, and the lady come out and done an assessment on Mum and explained to us that they would continue to do the service as long as she needed it, and it could go to the long-term care. Yes, we felt really supported. Sophie, the lady that come to see Mum, built up a really good relationship with Mum, always pleased to see her. And she always done her best with Mum. She could do the exercises with her, she would do it. If not, if Mum was feeling a little bit sore that day and couldn't do very much, then she would just leave it. And as it progressed, she started to do more and more with Mum, which really helped her improve to get back to normality. We were really pleased with the service. Sophie was lovely with you, wasn't she? Do you remember her? She was the lady that had got the pen in her hair, and you always commented on that. I remember one particular day when she was getting Mum back to doing more and more things. She actually took her into the kitchen and you made a cup of tea for yourself. And what, did you make one for me as well?
Yeah, I think so.
You did, yeah. You made me first cup of coffee in absolutely years. So I was well chuffed with that. And then also, she really went above and beyond on this one. Mum needed a new pressure cushion, and Sophie went above and beyond and ordered one for us, and it arrived the next day, which we thought was absolutely amazing. She also took you on a little walk down the path, didn't she, one day?
Yeah.
Out there?
Yeah.
And got you ready for going out so that you could go back to your bingo and use your dabber.
Yeah.
And then she was also saying that she'll get them legs moving quicker than you think. And she did just that. Amazing service. We were well pleased.
Great. So I hope you enjoyed that as much as we've enjoyed filming that. And we've got so many countless examples of residents like Zena and her daughter Christine, who tell us about individuals that have made a difference to them. And that really is what this is about, that they recognise the individuals that are providing that support to them, whether that's a therapist or a carer, whoever that may be. There's familiarity there, and they trust them. And that element of trust is absolutely crucial within the teams and then the relationships between our patients and residents with our teams. So what we've tried to do up until this point is integrate as many of our urgent services into one integrated team. So that includes urgent community response, hospital at home, and that is not without its challenges. It has been difficult. We have organisational hierarchies and boundaries and different reputational, impacts, and we've also got national targets that we need to be able to deliver data for. So it's complex and it's challenging, and it takes the time and investment to do this. But what we have seen is that it works. So our length of stay has reduced from 39 days to 24 days currently for this cohort of patients that are in the community. So if we go back to the diagnostic piece, where we had 40% of domiciliary care could be released, that's what we mean by that. We reduce the length of stay, we reduce the number of hours of care that are needed from the start of a patient's journey to the end of their journey. But it also means that we're very responsive and take quite quick action in managing that through that MDT model, and because we don't have referrals between our professional groups, which is really, really key. So one of the things that we have really, really struggled with though, and I'm sure this will be real for everybody here, is digital aspect of this service. So we've naturally got 3 different organisations, we've got many different systems, we've got calendar issues around visibility of how we can put different professionals into different appointments and the oversight of that. So Matt will talk shortly around some of the solutions that we've come up with from a digital aspect. But that's a really key thing to think about. How do we actually enable our teams to work better together and have visibility between each other? Thank you. Okay, so the second part of the programme that we just wanted to draw a bit of attention to is around our hospital visibility and accountability. So we all have a part to play here, but actually from an acute side, this is returning to the absolute basics. So we all say that there's twice daily board rounds, and everybody will say that that's what really happens. And that may well be true. We may well have twice daily board rounds, but have we got everybody around the table that can actually take an action away from a board round that moves that patient's journey along? Probably not. And that's what we've really returned to, is some of those basic principles of how you run a board round with a multi-professional group that is action orientated. So we're trialling on a particular ward where instead of thinking about how many discharges have or haven't we had, it's around how do we progress those patients that we have in our wards along their journey to actually realise their estimated date of discharge, and that estimation is actually fairly accurate, that we don't just keep changing the EDD, which I think everyone will be familiar with. And at the point at the patient is medically fit for discharge, how do we then enact the next phase of their journey so that we haven't got wards full of patients that are medically fit? And Jo will come on to that a bit later around what that means to manage that transition. But again, doing some of these basic principles and doing them regularly and doing them right has enabled us to, in our trial area, to see a 15% reduction in length of stay. And these aren't big numbers that you need to achieve to have a cumulative gain. These are small numbers that incrementally make a massive difference, and a 15% length of stay reduction is huge. And that's what we're trying to see in our scale out of this whole model. And having the visibility around what are the actions that we need to address for this particular patient to go home or go to their care home or their family home, wherever that may be, what needs to happen for that individual, and having visibility of that is really how we're driving this model. So I'll hand over to Joe now around the pull model.
So as Leslie touched on earlier, within the diagnostic, there was a couple of opportunities that we saw around discharge. So actually that suboptimal length of stay that we saw in the acute, but also the overprescription of care when somebody is actually being discharged from the hospital. I think with the implementation that we've got within the acute, having a lot of rigour around the activities that need to happen, and we've also got the local integrated team that actually can support an individual with a higher level of needs, we can really get into the space of transforming how we do discharges, and it's a really exciting space to be in. What that actually looks like is what we regard as the pull model, and that is individuals from the local integrated team reaching into the hospital and actually starting to plan discharge from the day of admission. Again, it's probably something that we talk about. We need to kind of start that planning straight away, but actually what we're doing in Coventry is definitely doing that, which is, again, a really exciting space to be. I think with the community actually planning that discharge straight from admission, not only are we on the front foot about all of this, but we've also got individuals in the community that know the services that are available, know how to kind of manage that risk, and therefore can actually provide that optimum short-term outcome to individuals that previously we might have been seeing in pathway 2 and pathway 3. So just going back to the diagnostic, 30% of those were actually deemed as being non-ideal. Those individuals can definitely be going into a more independent setting with the pull model being implemented. I think just a couple of things to call out on here. One, which I've talked about in terms of the kind of suboptimal short-term discharge, but also within our length of stay, you can see in the bottom right-hand corner already within the trial space, and there's a bit more work to do, but we're having a significant impact in terms of the length of stay when somebody's deemed medically fit for discharge to actually being discharged. And we've also got a really great quote in the top right-hand corner around somebody who was part of the hospital team. Their mother-in-law actually went through the process and had some absolutely glowing feedback. As we've kind of implemented this, we know that actually a lot of the activity that was previously done in the acute has now been moved to the community. And as part of that, we know we need resource in the right place. I think to what Leslie mentioned earlier, we have got the right resource in the system. We just need to use it as effectively as possible. One of the things that we are doing with the pull model is going, actually, with our discharge team that you've got in the acute, do we actually want to move them into the community? Do we want to get them more into that proactive space so that we can keep individuals in the community for as long as possible?
Okay, so what sits behind all of this, which Leslie mentioned at the beginning, is around our workforce and leadership. So I think it's fair to say this is a fairly big transformation and quite ambitious, what we're trying to achieve. It really comes from our executive level leadership being aligned and coordinated, but also willing to challenge each other and to, I think, stay true to the model that we're trying to deliver. And that has cascaded really through our sort of senior leadership team here and within our design groups as well. We've got a really good, trusting, safe environment that we operate in. And that has taken time, and as I've said, that's not been easy. It's taken the time and the investment to get there and to keep focused on what really we're trying to achieve. One of the things we did from the very outset, which I think has been a success so far in the programme, is we've applied and adopted a matrix leadership model. So by that I mean, for instance, I work in the acute trust, but I'm leading the community integration element. And my colleague Sally in adult social care is leading the hospital processes side. And that's been, again, challenging when you don't know an organisation like you know your own organisation, but equally you can see then why we operate in silos historically and what the opportunities are to work differently. And having someone with fresh eyes and fresh perspective asks different questions. And that's worked really, really well. And we've maintained that level of matrix working across the whole entire programme. And it was something that we thought to do at the beginning, but I think that has really helped to get where we are now. This is massive to integrate 3 organisations in a whole different level of care provision for urgent need in Coventry. but some of the benefits that we are seeing for both our patients and our workforce, I think, are really demonstrated here in the quotes. So the fact that the programme has given staff a voice and allows individuals to do the job that they were trained to do. So we haven't got individuals that are sat at a desk filling out referral forms and repeating their information over and over again. We've got people that are in a trial space, that they are working up to their skills limits of what they should be doing and what they were trained to do, and that's exciting. They're working with people from across organisations that they've not worked with before, that now they would pick up the phone to manage a patient. That didn't exist before this. We would have just written a referral form and then it would have gone into the ether and it would have taken as long as it took, really. The methodology that we've used through the programme has really been built around that concept of trialling. So we trial something, and then if it doesn't work, we refine it. If it works, we keep it. But again, it's the time and the energy to work with something small and keep building up over a period of time. And that's the whole concept that we've applied throughout the programme, is the trialling and redefining and keep going and maintain the vision that we're trying to work with. So we've got thousands of staff really to bring on this journey, and in some ways it feels like we're at the beginning of the journey, but it's good to do something like this to reflect on how far we have come, and we have got a whole group of staff that want to make this work and don't want to revert back to where we were prior to Improving Lives. Just hand over to Leslie. Oh, Matt, sorry. Thanks, Matt.
So I get the fun bit of talking about digital. So I think, as Cara said at the start, like, we are really starting to get to the limits of what can be achieved in the current ways of working with multiple organisations using different systems, a challenge I'm sure everyone has heard before. But also some of the bits that Joe raised around being able to pull someone out of hospital as soon as they're admitted. Like, how do you know they're there? Is probably a reasonable question. So I wanted to talk about two big chunks of the digital enablement for this work. The first is the single intermediate care system. Now, I think everyone's probably heard practitioners talk about it would be fine if we all worked on the same system. That is often an impossible thing to just deliver. And I think one of the things that's been really good in this programme is that we've approached that with a very specific use case. So here, as Cara talked about, we've got the local integrated teams who are working together on a single caseload. There's a very specific use case which we need to deliver for. So what we're putting in place is a single, effectively electronic patient record that allows access, and everyone is working on the same system across social work, so the social workers who are working on this, the acute clinicians, so whether that's the consultants who might be overseeing someone in a hospital at home type pathway, or it's the ward staff who are making sure that the community understand what's going on with that individual at the point that they arrive. All the way through to actually the carers who in Coventry work for private organisations but are delivering some of that hands-on reablement type support once the person is home. All of those people are in a single kind of shared environment and able to work off the same care plan, which means that that care plan itself is then effectively covering the full holistic need around the individual, everything from reablement to existing care needs all the way through to what is their kind of medical plan during their hospital at home pathway. So that's the kind of like the model we're doing. I just wanted to kind of highlight a couple of things that actually enables, because digital is all well and good, but it's not useful unless it changes something. So first up is carer feedback. So Cara referenced the length of stay in the community shortening by about a third. We're pretty confident that we're going to be able to go much further. At the moment, when a carer goes into a home and they're providing a reablement type offer, if they see that that resident is improving, we ask them to provide feedback. We don't yet have this digital system in place, and at the moment that comes back on a weekly type frequency because it has to get manually collated and sent through. When we put this live, that information will be instantly available to the clinicians making the decisions about what happens for that individual's care. That means that the step down, instead of it taking 4 days, will take 2 days, and that's 2 days that we're effectively taking out of the length of stay and progression for that individual. Another really important example to pull out here is Cara talked about resource planning across 3 organisations and 3 different workforces. What this will enable us to do is to be able to live see across that integrated workforce, where are people, where is our capacity, where can we allocate the most appropriate worker. So I think Cara also touched on the people working at the top of their skill set. We want to maintain that wherever we can and make sure that we've got the right workforce to support the population. So effectively, someone is in urgent need, we can live see across the entirety of the city where is the capacity of the right people to go and respond, and effectively get them there in sub an hour is the kind of the target. What I did want to build on is there is one thing that we have not yet done. So in going live across the whole city, we are going to build teams which are broadly the same. So every area will have a local integrated team that's the same. What we are aware of, though, is that the populations in those areas are different and they vary. But what we don't have yet is good enough data to actually know what that should mean for the workforce. Through this shared system, we are also going to be able to record who would have been the right worker to do that intervention. So for one of our Band 7 clinical practitioners turns up and goes, I came here for this reason, but actually, you know what, this should have been a physio who came here and did this visit. They would have been best suited to do this. We're going to be recording that data, which means that it will be a longer period of time, we'll be able to optimise that workforce for the actual demand of each of the populations. And the ambition is that in 5 years, these teams that support each of these local areas actually look quite different and are effectively tailored to those individuals. Just flipping a little bit to talk about live visibility. So Joe talked about the discharges being led from the community. One of the things that's required to do that is really good visibility both ways, so that the community can see what's happening in the acute and the acute know what the plan is for the community. So to give you an example of what we're actually going to be able to do is, as the local teams are planning those discharges, the wards will be able to live see what the planned discharge is. So when is that care package in place? What is the start date? What is the care? What do they need to communicate to the resident? And what do they need to communicate to the family who are going to be potentially on that ward? Likewise, the point of how do you know they've turned up? We're also able to give the local integrated teams live visibility of the people who have walked into the acute. Now, there are two parts to that. One is this person's been admitted and you need to start planning their discharge because they're one of your people. But equally, if there's someone who's already kind of being supported and they have made it to ED without us knowing, whether they've kind of self-conveyed, family members conveyed them, or an ambulance has taken them, we'll know that instantly and actually be able to potentially intervene and avoid the admission in ED. Did want to just build on one of Cara's points around the hospital and the kind of visibility and accountability. In order to actually get that to happen, you need visibility of whether or not it is happening, not just visibility of the outcomes of it. So at the moment, everyone will know, okay, we've got this many discharges so far, we've got this many planned. What you might not know is actually across all of the hospital, which patients haven't had a good action allocated to them this morning. And what are we going to do about that? So instead of being reactive, we are, instead of being reactive, we are behind on discharges. We can now be proactive of this person who may be halfway through their interventions in the acute hospital. Are we actually progressing them as fast and as quickly as we possibly can and providing the right support? So that's all the kind of direct piece. Just one quick note on the system visibility. Coventry, we're also going to move towards how are we actually sharing the system level visibility. So as execs, how can you understand where the pain points are in the system quickly? I'm not going to talk about this now because there is a talk tomorrow morning at 8 o'clock in the exhibition from Leeds who have just done a very similar thing. So just a bit of a plug for that one. I'll hand back over.
Okay. So hopefully we've given you a bit of a sense about the new ways of working and the new enablers that we're putting in place to deliver this model. And you'll have heard us talking a lot about designing and trialling, and that's where we've been for the past 5-6 months. And now we've landed on what the new model is. Now we've got to implement it. And I think you can get the sense of the scale of that task. So we've got, thousands of staff in the hospital who will have to embrace new ways of working, over 150 staff from across the system who were essentially throwing up in the air and landing into these new integrated teams. And as you would expect, there's a comprehensive staff engagement and comms piece that goes around that. And we're trying to think of creative ways to engage staff in this model. And that's Debbie, who's one of our discharge team, forever captured in animation. But I think, I've got a call with the union tomorrow morning to talk about the change that we're going to be taking staff through in this. But what gives me, I guess, confidence is people saying things to me like, please don't make us go back to how it was. And I'm an occupational therapist by background, and I've lived and breathed hospital discharges, and I would want to work in this way. So it gives us that reassurance that this is good for our staff. We've had really good engagement from our wider stakeholders. So we've got 8 primary care networks in Coventry, and we work with the West Midlands Ambulance Service. And we spent a lot of time with them at the beginning of the programme, understanding from their point of view as, I guess, users of the service, what kind of response are they looking for? And we've built that into the design, and they've come on the journey with us. What's been really exciting about this programme is the engagement we've had from public health in Coventry. So we have, I guess you could say it's PHM light, because we're just starting to dip our toes into population health management, but we have had support from public health around understanding the needs of our local populations, and that's had an influence in how we've set up the local integrated teams in terms of the resources we put into different areas. And we've also had engagement from our local community groups, particularly around the health equity element of the model, to try and understand the diverse needs of the people who live in Coventry who will be using this service. And whilst the population health management and community engagement elements have been quite modest, at least we're doing it. At least we're starting to try and do that and sort of like lean into it. And it gives me, I guess it's exciting, but it gives me a bit of reassurance about what comes next in terms of ICSs and how we need to work together as a system. And it gives you a sense of the kind of growing partnerships that we've got in Coventry and what it might look like next time we do transformation. We can lean into those things even further. So we're going to start implementing, we're going to go live with this in January because we're a bit crazy like that, but we'll tell you what our rationale is for that in a minute. So this thing's going to be embedding early next year, and we'll be up and running. And how are we going to know it's working? From a patient point of view, we know it's working when people are having improved outcomes and are more independent at the end of what we deliver for them. For the workforce, people will identify as being part of an integrated team rather than working for the council or working for UHCW. And this real thing about being able to give people a way to do the job they train to do is really, really important. From an operational point of view, hopefully, standing here this time next year, I'll say, ambulance handovers have improved. We're not having meetings every morning deciding which electives we're going to cancel because we've run out of beds. We're on top of our backlogs, a bit more on top of our backlogs. We've been able to right-size our bed base and get that mix between elective and emergency more proportionate. And we'll have the capacity in adult social care to respond urgently. And as you would expect from a transformation on this scale, there's a comprehensive benefits monitoring plan that goes alongside this that system partners are committed to, and elements of our financial recovery in the system are kind of counting on this delivering. And that plays through in bed day efficiencies and adult social care spend. So we are halfway, I would say. And at this point, we're confident that we're going to deliver this thing. I think the when are we going to land it and when are we going to feel it's embedded is what we still need to answer. But we're going to do this. We're behind it. We've got brilliant leadership all the way, and I think you can get a sense of the excitement and the ambition to do this. But I'm sure you've been thinking of lots of questions as we go along, and we're going to move into the Q&A panel now where Sarah will put us through our paces. She said she's going to be nice, but we'll see. And then there's time for you to ask questions at the end as well. So thank you for listening so far. And that's the little Menti code if you need to do that. Okay, Sarah.
Okay, yes. We'll do this sitting down. If you still want to put some questions on there, you can. We've got a screen here that we've been tapping through, and we can see those things come up. But I imagine that a lot of you are grappling with the things that we've been talking about. So we're going to kick off with some questions, but we really do want some from you, and also advice, because everybody's doing this at the moment. So let's share. Let's create a community of sharing. What have you done on this? How is it similar? How is it different? Let's learn together. But the first one, I have to say, when Leslie said you were going to kick this all off in January, I was you know, that's a very ambitious time to do it. So we're going to hear from them. Why are you rolling this out more widely in January?
So I think when you talk about anything over winter, I think the general feeling is let's not do anything else because it's going to be so awful. And that was probably our initial reaction was, oh, we can't do it in January because that will be a terrible time. And then we kind of checked ourselves on that and thought, well, why wouldn't we do it in January? Because that is the time that we need this model to be in place the most. That is when we need this to be tested and put it through its paces and make sure that it stands up. So I was saying from a local integrated teams perspective, we need to be challenged when winter's the time to do it. So instead, what we've tried to do is embrace winter and go with January as our launch date, but really wrapping around and I think emphasising that leadership approach. So our executive team, me and my corporate director colleagues will be allocated individual wards to go out to our ward areas across winter and to make sure that we are absolutely clear that we've got a local integrated team that we can transfer patients into and we can keep flow and maintain movement. And that is really, really key. So we are using winter as our test base because if it doesn't stand up in winter, that's when we most need it. So it's got to, and that gives us a really good platform to test that.
Okay, great. I think if I were listening to this, I'd think, well, yeah, I've heard some of this before, actually. It feels a bit familiar, integrated teams. We're going to, you know, all work together and it'll change. So what's really different here in Coventry?
Yeah, so, yeah, lots of these things have been tried before. Absolutely, that is right. I would say what I haven't seen is the method that we've used. So and I think Leslie mentioned this at the beginning, we haven't decided what we think the problem is and then we've thought of a solution and then we've just thought, let's do it and then we'll move on to the next thing. We're creating it as we go and learning as we go and using the diagnostics and holding on to a vision that is not absolutely concrete because we're learning from the staff that are telling us what's working, what's not working along the way. So I think the method is different around the trials and the time commitment that we have been around this and will continue to be around this to make it work. I think that gives it the sustainability element, which I think is probably most at threat when you do any sort of transformation, is the sustainability. But we're committed to this.
Okay.
I think there's something as well about what's felt different about this for me is it's not us on our own fixing our bit and then they fix their bit and they fix their bit. We've all got together and we're sharing the responsibility. And you hear that play out in the leadership conversations as well. It's like, this is what I'm dealing with in my organisation. Can you guys help me with this? Yeah, this is what I'm dealing with in my organisation. And that kind of transparency around what people are personally dealing with really helps to build trust. And you see that at the exec level, you see it at our level, and you see it with the middle managers as well, because we've got, you know, they have really, really embraced this. They're like, we don't care about the boundaries in the organisation. This is how we want to work. So if you could just get out of our way a little bit. We're used to working as teams together. So, you know, I think that's been really different. We have really empowered our staff to get together, leave the organisations outside, et cetera, and there are wobbles around that because people do get a bit worried about making decisions. But if you keep backing people up and giving them the air cover and showing modelling that behaviour right the way through, that's what I've noticed is really different about this. And we're going to need a lot more of that to see us through the delivery bit as well, where the rubber really hits the road when you're getting into contracts, estates, who's in charge, all of that. That's where the real test of those relationships is going to come.
Yeah.
Just one thing I wanted to add to that, I think, is one thing that's very different, I think, is the scale of ambition. So in Coventry, and I can see some of the questions coming up. Like one of the questions was, does this include district nursing? And the answer is yes. It's that, like, this change genuinely includes all health and care urgent demand, and that means that, like, at the end of this, there won't be a separate UCR service, there won't be a separate reablement service, and like that scale of ambition is not something that I've seen elsewhere, and that has been for me personally, it's been an incredible place to work for that. Just like to work in an environment with that level of ambition has been brilliant.
Yeah, I think just I suppose last point on this one. I think for the workforce who've been designing this, like talking about this as it's not just here's the short-term fix of we're going to sort out urgent and emergency care is very much like starting to take their aspirations and go, actually, how we're going to build from this, and making sure that actually what we've got here is very much the foundations. Like, we know that this isn't the end, and we've got so many individuals within kind of our design groups that are going, what about proactive? How do we step into that space? And that's exactly what we want to be doing, is almost trying to hold them back a little bit and go, let's not bite off too much to start with, but very much looking at this as the foundations to build from.
Yeah, I'm going to pick up some questions that we've got through, and quite interesting this bit about working with the ambulance service, and how have you gone about that, and how do you envisage that developing as you go through, and linking that to whether this is a really 24/7 offer. How are you going to expand it and manage the out of hours process?
So, I mean, you know,
those are quite difficult questions, so well done, whoever put those in there.
So West Midlands Ambulance Service, Coventry is just one of the places they're serving, right? So the main feedback from the ambulance service and from GP colleagues is, please make it straightforward. Just give me one service. Just give me one number that I have to ring and I can hand over, and I can trust that you will take my patient. Not a directory of services that I have to go through while I'm on site that says, this service runs until 4, but then between 4 and 6 you get this one, and after 6 you have to go here, and they can't do it today because they can't, and that is a nightmare for the ambulance service, and I completely understand that. So their greatest ask is, please make it easy for us to do the right thing. And also, we don't want to bring patients to hospital, by the way. You think that we do, but we don't. We want to keep them at home. Please make it easier for us to do that. So that's really loud and clear what I heard from every paramedic I spoke to. And also, you know, we did get good engagement, considering they're dealing with Coventry, Birmingham, so we are just part of that picture. And they talked to us about places where it works really well for them, and that was the kind of principle of it. It's responsive, that sense of, yes, give us the patient and we'll sort it out, okay? So that is kind of understanding, how do we set this service up so it works for the people who are using it, who are GPs, care homes, and the ambulance service. And that was the message we got. I think there's more to go after there in terms of more integration between the ambulance service and the urgent community response bit, more relationship there. And we're starting to look at pushing the boundaries of what the urgent community team can do in terms of their kind of pre-hospital diagnostics, etc. And you know, we were talking to Sarah last night about opportunities to have more kind of on-site responsiveness to patients who just need care to tick them over. So I think there's more to go after there. But if we can show our ambulance colleagues that we've listened to what they wanted and we can put some of that in place, I think that builds a bit of trust and relationship as well. And it's like, we've listened to you, and now let's see where we can go next from that. I think the question about the 24/7, this is the local integrated teams are kind of 8 till 8, 7-day-a-week type response. What we want to see happen next. So we talk about the local integrated teams, but this whole system is one Coventry integrated team. So I want that nurse who's in the patient's home to have a way to speak to our doctors in the hospital when they need support. That's proper integration. That's picking up the phone to your colleague. That's where we want to get to. So one Coventry integrated team. And we're starting to get into our integrated out of hours offer in Coventry and Rugby at the moment. So I think, like what Joe said, this programme is about the urgent health and care response, but it's the kind of blueprint for how we're going to do things next when it comes to out of hours, when it comes to planned nursing, when it comes to the whole kind of planned, proactive and urgent health and care response for the adult population in Coventry are the next phases of this. We'll come back and talk to you about that next year. We'll see how it's going. But it's the beginning of that kind of integration journey, really.
Okay, you're showing a lot of confidence about next year, so we'll put it on the programme. I want to go to a question that someone's asked that is slightly different, but actually really gets to the nub of some of the leadership stuff that you've been talking about. And someone's asked, are you comfortable that you have truly open book finance? That's often a barrier amongst partners. And absolutely, you know, it's a bit like a marriage, isn't it? You all get on until you start talking about money and then differences come out of the woodwork. What's the experience of that when you've started to have that conversation?
I can jump into this. I think there's a couple of bits in that in this programme we have ultimately kind of committed to. We are doing this within the resource envelope that we have, which means that we haven't had to get into some of those bigger financial conversations. But where there have been financial conversations, I think that probably this is where the point around the leadership is quite critical. That group of 4 people are running this and holding it every single week. And every time that there is a kind of a resourcing question, there is a very pragmatic conversation between the 4 of them of like, what are we going to do? How are we going to make this work? And I think that there is a commitment between them to like prioritise the resident and the resident experience, but also a level of trust that they're not going to screw each other over. And that's probably one of the biggest things, is that I think both from the local authority and from the 2 trusts, there's genuine understanding and acceptance of each other's challenges, and a commitment to help, and a recognition that unless that commitment exists, unless we continue to work together, like, it's only going to get worse. So I think open book finance, I don't think we've necessarily gotten into things that have required us to have full open book financial discussions, but in terms of the attitude and way of working, it hasn't actually caused us a single issue in the programme. And it's more about the culture, would be my...
Yeah, and I think that gets more relevant when you think about what's coming next in the health and care integration landscape. When you're talking about people coming together around delegated responsibility for populations, etc., it's a good place to start from where we are now. Because if you look at the benefits profile for this, the huge amount of benefits falls in the acute. The Community Partnership Trust are doing heavy lifting on this as well, but they're not going to see savings out of this. Actually, it's going to be more activity in the community, right? Adult social care have a financial benefit in terms of reduced reduced care hours. But we sat around a table and agreed the benefits together for our system, and everybody's putting their hand in their pocket and equally contributing to the programme. I think that's a really good place to be, actually, in terms of transformation, especially when there's an equal amount of money going in, but the benefits are disproportionately falling in different organisations. But as a system, we're sharing the benefits. And that's quite a good place to start from when you get into us coming together. You know, all those people who I showed up on the screen are also the people around the table developing our Coventry Place governance, where you really do need to get into a bit of transparency about what the risks are in your organisations and getting together around those and how you move the money around. So I feel like it's a good place to start from to get into those conversations.
Okay. There's been a question about general practice, and we've talked about this in terms of where general practice are, where GPs are, and how much they get asked for the medical oversight of community support, and are we just shifting the risk? How does that fit with also where you locate? Someone has asked where the integration hub is.
Yeah.
So what's that sort of connectivity that we see between the acute and community? Cara, do you want to...
So I think one of the really important things that we're trying to do is when we're mapping geography, we're trying to think about what is the landscape that we're operating in and all of the different established networks that already exist. So our PCN network landscape. What we wouldn't want is to have, 3 or 6 or whatever local integrated teams. That means that GPs have to actually navigate 3 of them, because then we've not achieved what we wanted to achieve. We're trying to make this as streamlined and simple as possible. So we're trying to balance in our sort of geography aspect of the design a lot of things around the established sort of frameworks that already exist out in the community, particularly in primary care, coupled with our population health management that we described. And that is tricky, but that's what we're trying to do. And we've been engaging with our primary care colleagues from the start in all of this around what would make the difference for you. I think that familiarity aspect that we talked through around our local integrated team being familiar and knowing the patients is welcomed. And our GP colleagues would probably like to have that, and don't because of the volume. And I think sharing that with our local integrated teams is exactly what they are supportive of. So I think we've got good engagement with primary care, but it's not easy to navigate this from a geography aspect, but we're very mindful of it, and that's why we're trying to plan it carefully.
Okay.
We have two of our two of our local PCN leads in the programme as well. So they're helping us design it, and they're kind of sounding boards for things. And I regularly go to our local GP board to talk about this. In January, they told me, your programme is doomed, Leslie. It's doomed, doomed, doomed. I don't know, what do you think? Is it doomed? So hopefully we'll be able to reassure them that it's not doomed. And I said, it's not my programme, it's our programme. So I think we have, they want this to work, of course they do. And I think, GPs I talk to, it's a bit like the ambulance service. They're like, I don't really care how you organise yourself as long as someone answers the phone and doesn't ask me to call this team who does this and call this team. That's all I really want. I just want someone to answer the phone and help me. I've got a patient in front of me. So, they are our, if we want critique and we want to know if it's really going to work, we know where we go and we'll get an honest answer.
Yeah. Matt, you want to come in?
Yeah, just on the question about where the hub is located, I think, just to be clear, there is no hub. And that's been a very deliberate choice of not putting in a triage step. Like, that hub would effectively be another process step that everyone would have to jump through, and it's another step to make fast. So one of the big things that the digital enablement has enabled us to do is to get rid of that completely. So the local teams are responsible for coordinating their own demand and managing those caseloads. And that means that we actually make it possible to do clinician-to-clinician contact at the point of need. So if you're an ED and you need to turn someone round, there is one phone number. Depending on the postcode of where that person is, you are connected to the clinicians in the team who are going to support them. And it means there is no referral form, there is no working out where to send it, and there is no hub step to triage that through. So some of that comes down to process design, but a lot of that has been around the principles of clinicians wanting to talk to each other about this rather than it being a fill out a form element. So yeah, there is no hub, but the teams are located within each of the communities that they serve.
It's a really good model. And someone asked whether you'd been able to ban the word referral, which would be really so good, wouldn't it? Just a pure process.
Handover.
Yes.
Handover to colleagues, refer to services.
Yeah. So someone's asked about, you've talked a bit about the impact this has had on Pathway 2 and Pathway 3 in terms of your discharge. But what impact has it had on Pathway 1 with people who've got no criteria to reside? And in particular, I'd like to ask, has this made an impact on weekend referrals and weekend discharges?
So I think if we just pick up on the weekend aspect, so we come to a grinding halt at the weekend, basically. That's been how it normally operates, sort of in an acute trust. I'm sure everybody's familiar with that. But it doesn't need to be like that. And some of the things that I talked about earlier around our board rounds being consistent, we know that if we operated the same model at the weekend as we do in the week, that we would have 74 beds on a Monday, which would feel like a miracle, I think. But these are small things that we need to do differently. So absolutely, the impact on Pathway 1 is that we don't have hundreds of medically fit patients that are remaining in hospital, that we are moving patients through quickly, pulling them through the pool model that we've described. So that's a huge, huge impact on that cohort, absolutely.
Great.
Yeah. We don't distinguish between the different pathways. The only question that's asked in the acute is will this person need something to go home? So effectively, we didn't really talk about it that much, but these local integrated teams manage home-based and bed-based care. It's not, they're not separate pathways in this.
The criteria is if they're urgent.
And fast track and end of life, and it's anyone who has a need to leave hospital.
And I think that's been a big part of how do we shorten up that length of stay. One of the biggest findings we found was that there are lots of steps you have to go through to get someone out of hospital. You have to plan things, you have to put things in place. And often those things do just take some time, but there is also nothing to stop you starting them much earlier. So the pull model element and starting much earlier has been one of the biggest levers on shortening the post-medically fit or no criteria to reside length of stay.
Okay. There's a question here about, you've talked about lots of continuous improvements and dig systems that will make this better as you progress. How have you defined the MVP without blocking yourselves by striving for perfect? And it's that bit of that discussion that we talked about. How do you get sustainable improvement when we're in the sort of, right, we've done this now, how do we keep people going? How do we get them to really change their practice in the long term? Who wants to answer that?
I can jump in front.
Okay.
I think quite a lot of that is actually tied to what Kai, you mentioned earlier around the methodology, constantly trialling to make sure we do actually have the right product and the right process in place. I think in terms of kind of the MVP/sustainability, I think very much what we've looked to kind of deliver is, digital products that make us work today, rather than thinking kind of what do we need in 2 weeks' time, but actually as part of that what we're getting is the user stories that we need there, and very much user-centered design, so that actually whatever we're creating for today, we know that actually we can create sustainable solutions that build on what we need rather than just what would be cool, for example.
And I think that the thing that Matt talked about in terms of not just having performance reports that tell you how you're doing or where the pressures are, but reports that tell you, are people doing the things that we know create flow? So, you know, when I was a group manager back in the day, I would go around the wards with like, have you got any discharges today, and what are we going to do, and how are we going to unblock them? But if I could go around and say, right, your guys need to do X, Y, and Z because that's going to get flow in your ward. Have you done it? What are you going to do to make sure it gets done? That's a very different conversation, and it enables your management team to be able to push for the right things. I think the question was about the continuous improvement, and I think, you know, we're in the heavy lifting of designing and implementing, but we are not naive to think that the heavy lifting will continue on this, and it has to continue at every level, doesn't it? It's your managers on the ward, it's your middle management, it's your exec team, and how do you give people at every level, it's at the system level as well now, isn't it? How do you give people at every level the information that they need to look in the right places, to apply pressure in the right places, to understand where things are going off? And I don't know, Matt, if you could talk a bit more. I know you said it's going to be in a session tomorrow in what they're doing with Leeds, but if you could talk a bit more about that kind of system visibility tool that we're thinking about building and how that will help.
Yeah, and so I think Cara and Leslie talked a lot there about the visibility that enables the action every day. The continuous improvement is that slightly different lens where you look back and you say, actually, over the last month, what was it that caused us to not perform as well as we could? And there's the same conversation about what is the right information you actually need in that, but probably the more important bit is driving the behaviour of that being something that people do, and having the constant focus on it. So within UHW, there is the UHWI improvement piece, and our absolute ambition here is to build into that whole structure of improvement the specific areas that we've looked at. So effectively enabling that model of structure and focus on improvement to continue. In the community where that structure isn't there, we're effectively building a structure of improvement. I mean, ultimately it comes down to an improvement meeting where the right people get in a room. Now, those things will always fall away if people don't see value in them. So getting them so that they are critical, valuable, and expected is one of the big things we are working through at the moment. So is the right information there? Do people feel like they can take action? Do people see it make a difference? Are the things that we will be putting in place with that. And Leslie asked about the system level. Well, ultimately we need to feed all of that together, because there will be certain challenges that might exist in the community where actually what we need is support in the acute, and vice versa. So at a system level, we are effectively, that system visibility piece will be every month as a leadership team across the system, are we able to understand, okay, where we need to focus right now is the southeast lit. Something has gone wrong, which means that they are not being able to pull people out of hospital same day. Something is causing there to be a delay, and we need to be able to see that at the exec level so that we can then say, okay, well, what support is required in that local team to get the performance back? Performance doesn't exist by itself and continue to exist, like it does slip, whether that's when people change, when demand increases, and it's how do you get the right focus and attention that means that it gets rectified quickly. Is probably the summary.
Okay, I'm thinking time I just want to come back to one point. When we started with the questions, we were talking about the fact that the teams work well together and you've built up this trust. If we go to January, when you're starting to do things, and this is probably going to be one of our more extraordinary winters, I think we can call it that, what are you going to put in place to ensure that those relationships sustain through the really difficult times and when the pressure's really on? What are you planning with your colleagues that you're going to do about that?
I don't know if our exec team actually know what we have planned for them in January yet. So we are, in terms of this is a whole organisation approach, isn't it? Like our deputy Q says to us, this has to be the way that we run the hospital now. These have to be our new way of working. So to support, we need to wrap a lot of support around staff for this. We're going to have our exec team, our corporate team, on the wards, supporting, making sure people understand what they need to do, making sure that it's really clear from the top down that this is how we do things now, and the role that everybody has to play in that. I think the support, that level of support to embed this new way of working will need to go on and on and on, and it will have to become part of how we do things as well.
Yeah.
I think the support for the integration in the community is really, really different. That is about lots of conversations with people who are going through significant change around why this is the right thing to do for patients, why it's the right thing to do for staff, and that is a lot of TLC, a lot of conversations and support, and we've got a lot of engagement from workforce and unions, etc., around that. But the other thing that we still need to develop is, how are we going to run this thing? So you've got adult social care, you've got acute provider, you've got community provider. Who is responsible for this? Who is accountable for this? And how are we going to share that responsibility and accountability? And that gets you into clinical governance, it gets you into finances, it gets you into workforce. And that is something we have to develop for Coventry as well. We've got the model now, how are we going to run it? And that, again, will be another test of our leadership and our relationships, but it's the right test to have.
Thank you. Anything else, Cara? Last word?
It's fine.
Okay.
Yeah,
Thank you very much, colleagues, and thank you for coming to listen to the Coventry story. I think they deserve a round of applause for that.